ultrasound for the diagnosis of the duplication abnormalities needs a standardized rendering technique, and this is very important. It is to be understood that whenever you get a rendered image, whenever you use a rendered image to differential diagnose the duplication abnormalities of the uterus, it is essential that on the multiplanar planes, the true orthogonal planes are to be achieved on both A and B, which will automatically make the third plane also orthogonal and bring the dot on the or close to the fundus if you are going to use the multiplanars only for the differential diagnosis, or if you are going to use a render, bring it right on the green line to follow the curve of the endometrial cavity, and only then should you diagnose what is the abnormality that looks like. It is on this 3D ultrasound picture, it is on this coronal plane picture that you would take all the measurements, and this is very, very essential. Apart from that, when the rendering is difficult, especially in the cases where the scan is done in the early proliferative phase, then when the endometrium is very thin, or at times it is a grade C endometrium which is absolutely isoechoic even the pre-ovulatory phase, in these cases you can use what is called OmniView plus VCI, which is volume contrast imaging, which improves the contrast and which can give you the shape of the entire endometrial cavity. Coming back from the methods to the actual classification, when we were discussing so much about the duplication abnormalities and differentiation between the bicornuate or bicornuate, septate and the arcuate or the normal uterus, what is the importance? Why are we talking so much about the duplication abnormalities? It is the subseptate uterus, the partial septum, which is a major factor for predisposing a patient to missed miscarriage. There are a lot of pregnancy complications, there are a lot of fertility complications which are seen with the septate uterus. And according to this one study of about 278 patients, it has been shown that the patients with uterine septum, 43 out of 278, had repeated spontaneous miscarriage. So it's a major cause of recurrent pregnancy loss. 71 had spontaneous miscarriages, 82 had primary infertility, 20 had premature delivery, 76 patients had ectopic pregnancy. That means the pregnancy complications are very severe in the cases of presence of uterine septum, and it's not only the pregnancy complications, even the fertility is affected. It was thought once that it is because of the vascularity of the septum. The septa are usually less vascular, and that is why these complications occur, and that is the reason for the affected fertility or for the subfertility. But it has been proved in the studies that more than 71% of the septa are vascular, and not the major difference in the vascularity of the septum and the bicorporeal uterus is one, the arrangement of the blood vessels, which is V or Y shaped in the bicornuate uterus or the bicorporeal uterus, and it is unorganized in the septate uterus. Now let me bring you take you back to the development of these two Mullerian duct abnormalities. We know that when we are talking about the bicorporeal uterus, it is a defect, it is the arrest of the fusion phenomenon of the development of the uterus. Because it's an arrest of the fusion, that means the myometrial fibers are still maintaining their alignment, and there we know that the normal vessels in the myometrium are parallel to the myometrial fibers, and therefore because they form a V or a Y pattern. Whereas when we are talking about the septum, it is actually the fusion which is complete, the alignment is still remaining, the absorption is still remaining, and we again know that the myometrial fibers are the myometrial vessels are parallel to the myometrial fibers in the outer layers. And therefore, because they are already crisscrossing, the vascular pattern is also not V or Y shaped, it is deranged. Now, if I say that the septum, if we go back to that concept that if the vascularity in the septum is less and therefore it leads to fertility complications or leads to abortions, are we completely right? I already mentioned that more than 71% of the septae have been found to be vascular, but the major thing is that it has a higher resistance vascularity than the normal myometrial vessels. But there's a huge overlap, because if you're talking about the myometrial vessels, the RI ranges between 0.54 to about 0.84, whereas here it is 0.68 to 1 RI. And this higher resistance probably is maybe one of the causes of leading to difficult implantation or abortions. But when the vascularity is more, actually the pregnancy complications are more, and the reasons given for that are quite interesting. Whenever we see that there is more vascularity in the septum, which means that there are more muscle fibers crisscrossing, because there are more muscle fibers crisscrossing whenever there is a normal peristalsis in the rest of the myometrial fibers, it is in this focus that there is totally chaotic contractions, and because of this chaotic contractions the implantation is not possible. The second important cause is the resistance itself that we mentioned. Because the resistance in these vessels is high, the branches of these vessels which supply the overlying endometrium, they also have a higher resistance, and therefore there is insufficient supply of estrogen to the endometrium, leading to inadequate development of the estrogen receptors, and therefore the implantation becomes difficult. The third important thing is that when we see that there are more muscle fibers in the septum, that more vascularity in the septum, that means that there are more muscle fibers in the septum, that means there is a less of connective tissue, and if the connective tissue is less, there is a less chance of decidualization, and all these contribute to the fertility problems and early abortions. That means that if the septum is less vascular, probably the fertility complications may be lesser as compared to when the septum is more vascular. Having discussed that, let us move to another controversy in the Mullerian duct abnormalities, and that is a T-shaped uterus. As mentioned earlier, whenever there was a narrow cavity, which I discussed in the very early slides, one of the very early slides, when there is a very narrow uterus, that's when it was called a T-shaped uterus or a disexposed uterus in the AFS classification. But this led to overdiagnosis of T-shaped uterus, and this was quite a problem, because whenever T-shaped uterus was diagnosed, people thought that they can probably dissect here now on the lateral walls of the uterus and make the uterine cavity wider. But this was quite a complication, because if that was tried in those patients where the actual uterus was small, the myometrial wall was not thickened, it would lead to rupture of the uterus as a complication of pregnancy. Therefore, a correct diagnosis of T-shaped uterus was very essential. And this was made very clear with the Estrogen classification. According to the Estrogen classification, whenever you see that the endometrial cavity is narrow with a normal uterocervical ratio, you have to confirm that it is an increased lateral wall thickness which has led to the narrow endometrial cavity. And this can be diagnosed by looking at the coronal section of the uterus, measuring the myometrial wall thickness, draw a line from the cornu to the internal os, draw perpendicular on this line from the deepest point on the lateral endometrial wall, and measure the distance from the intersection of this perpendicular to the lateral wall of the uterus, and if this distance is more than 1.4 times the myometrial wall thickness, only then it is a T-shaped uterus. So this confirms that it is a thickened lateral wall, and therefore metroplasty may help.